Other pacing modes. Ventricular pacing, dual sensing, dual response, VDD. VDD is generally used in the patient with normal sinus function who does not require atrial pacing. The advantage of this system is the use of a single tripole lead, that paces in the ventricle and senses in the atrium and ventricle. Disadvantage of VDD. Occasional atrial undersensing may occur because atrial electrodes are not attached to the atrial wall in these systems, and the amplitude of atrial electrograms may change with body position. In VDD, a single tripole lead paces in the ventricle and senses in the atrium and ventricle. Dual pacing, dual sensing, inhibited mode, DDI. During episodes of bradyarrhythmia, this system functions in an atrial or AV sequential pacing mode. Advantage: during sinus tachycardia or episodes of atrial tachyarrhythmia, the device does not track the arrhythmia, but it is inhibited. Disadvantage: DDI pacing mode is inappropriate for patients with permanent or intermittent AV block, because of lack of AV synchrony if a patient has a sinus rate higher than the programmed pacemaker lower rate, in which case the atria are controlled by the sinus rhythm, which is not conducted to the ventricles due to heart block, and the ventricles are paced by the device. Automatic mode switching. In advanced pacemakers, automatic mode switching is available, from DDDR to VVIR or DDIR, when the atrial rhythm changes from sinus rhythm to any supraventricular tachyarrhythmia, to prevent tracking of the tachyarrhythmia by the device which is now responding by inhibition. Dual pacing, ventricular sensing, inhibited mode, DVI. This pacing mode may be used in patients with AV block, and paroxysmal supraventricular tachyarrhythmias. It basically functions in AV sequential pacing mode. When tachyarrhythmia occurs, it will not track the arrhythmia, because there is no atrial sensing. Disadvantage: asynchronous atrial pacing due to absence of atrial sensing. Generally, DVI is not used when DDI is available. Chronic atrial fibrillation, AF, other chronic atrial tachyarrhythmia, and tachycardia-bradycardia syndrome. Patients with these arrhythmias should not have a dual-chamber pacemaker. The indicated modes in these patients are either VVI or VVIR. What about the ECG findings in patients with different modes of pacing, who have atrial fibrillation, AF, at the time of ECG recording? It is now reasonable to review these ECG patterns. VVI in AF with AV block, regular ventricular pacing occurs at the pacemaker lower rate, since there is no atrial channel to sense AF. DDI in AF with AV block functions as VVI, because no tracking of AF, but atrial channel is inhibited. In DDD and VDD in AF with AV block, presence of atrial sensing with dual response results in tracking of AF up to the pacemaker upper rate, with irregular ventricular pacing. DVI in AF with AV block performs regular AV sequential pacing, because sensing is only ventricular. Carotid sinus syndrome and vasovagal syncope. These patients generally have intact sinus and AV nodes, but may require intermittent pacing, to prevent syncope during bradycardia episodes. DDD is usually used, because of the combined vasodepressor and cardioinhibitory responses in these patients. Scanning hysteresis or rate drop response pacemakers may also be used. They allow for pacing at an intervention rate for a short period of time, triggered by decreased intrinsic heart rate. Asynchronous pacing modes, AOO, VU, and DU. These devices have no sensing and consequently no response. The chamber, right atrium in AOO, right ventricle in VU, or both in DU, is paced continuously at the pacemaker lower rate, regardless of the native rhythms. Use of asynchronous pacemakers. These modes are rarely used except during procedures using constant electrocautery, to avoid inhibition of pacing caused by sensing of the high-frequency impulses of electrocautery. The obvious disadvantage of these pacing modes is the possibility of asynchronous pacing during the vulnerable period, and initiation of either AF, in AOO, or VF, in VU, but fortunately, this is extremely rare. Choice of pacemaker mode. The following algorithm facilitates the choice of the appropriate pacing mode for each patient. Step 1. If there is chronic atrial fibrillation or flutter, use VVI or VVIR. If not, Step 2, in patients with paroxysmal supraventricular tachyarrhythmia, use DDD or DDDR with automatic mode switch. If not, Step 3, in patients with adequate AV conduction, use AAI or AAIR. If not, use DDD or DDDR. The only advantage of AAI pacing is probably the avoidance of a ventricular channel passing in the tricuspid valve, which is claimed by some to cause tricuspid regurgitation, that might be severe. Most authorities nowadays, however, do not prefer AAI, because of the possibility of developing AV block at any time, and advise the use of DDD with automatic mode switch in everybody, but those with chronic AF. Pacemaker syndrome, PMS. PMS occurs mainly in VVI pacing. It consists of signs and symptoms due to loss of AV synchrony, and/or retrograde VA conduction. It results from atrial contraction against closed atrioventricular valves, causing atrial distension. Manifestations of PMS: increased pulmonary venous pressure with pulmonary congestive symptoms, such as cough and dyspnea. Increased jugular and systemic venous pressure with manifestations of systemic venous congestion, such as neck fullness, headache, intermittent or persistent canon A waves, and liver pulsation. Atrial distension can cause AF, and diuresis, mediated by elevated levels of atrial natriuretic peptide. Low cardiac output manifestations, such as fatigue, orthostatic hypotension, near syncope or syncope, and chest pain. ECG in PMS. ECG demonstrates the pacing mode, usually VVI, present at the time of these symptoms and signs. Pacemaker syndrome with other pacing modes. In DDI in patients with AV block, if the sinus rate exceeds the pacemaker lower rate, AV dissociation may produce symptoms compatible with the pacemaker syndrome. In DDD in patients with severe intra-atrial conduction delay, the delay may cause inappropriate timing between left atrial and left ventricular contraction, leading to retrograde atrial flow. This may necessitate the addition of a coronary sinus pacing lead to advance left atrial systole. Management of pacemaker syndrome. Many patients may experience mild symptoms of the pacemaker syndrome and learn to live with these symptoms, but others will require intervention. Lowering the pacing rate in VVI mode and using the hysteresis function may promote more sinus rhythm, lessening the symptoms. Otherwise, upgrade to DDD is done. Can VVIR be an alternative to DDD pacing? Some consider VVIR an alternative to DDD pacing because it was shown that the change in work capacity correlates with ventricular rate during exercise, whether the ventricular rate is triggered by spontaneous atrial activity or by a pacemaker sensor. And patients spend most of their time during rest at heart rates slower than 100 beats per minute. This is not, however, generally accepted because AV synchrony is required even at rest and plays a great role in optimizing cardiac output and improving the sense of well-being and the quality of life. The atrium would consistently pace against closed AV valves, decreasing cardiac output, in VVI pacing with retrograde conduction, and in DDD pacing with long AV intervals so that P is closer to the preceding QRS. Rate-responsive pacemakers. Rate-responsive, also called rate-adaptive, or sensor-driven pacing, is the ability of a pacemaker to increase the lower rate in response to a physical or physiological stimulus. Rate-responsive pacing is based upon signals generated by sensor systems that respond to parameters or activities, correlating with the physiological need for increased cardiac pacing rate. Rate-adaptive sensors. 1. Activity-based sensors are very sensitive to vibration motion. Their drawback is that they may not provide feedback that is proportional to physiological needs. For example, climbing upstairs requires more work than going downstairs. However, going downstairs is usually faster and would activate the sensor more than climbing upstairs. 2. Physiological sensors provide some measurable index of activity, exercise, or catecholamine state, that can provide a more accurate input to the pacemaker. These sensors measure the QT interval, minute ventilation, or some metabolic parameters. Measurement of the QT interval. Pacers having ventricular pacing can measure the QT interval from the ventricular stimulus to the end of the sensed T wave, and modulate the heart rate based on this measurement. Measurement of minute ventilation. This system depends on the idea that the inspiratory tidal volume is proportional to the transthoracic impedance between the pacemaker lead and the pulse generator, which increases with inspiration and decreases with expiration. Its disadvantage is that energy is required to measure the impedance, which increases the current drain from the pacemaker battery. Metabolic sensors. Metabolic sensors measure physiological parameters, such as the blood pH, oxygen saturation, stroke volume, or temperature. The measured parameters can provide an accurate measure of a patient's metabolic needs, which can be used to guide rate responsiveness. Dual sensors. These systems use two sensors, an activity-based sensor, to provide fast responses at the start of exercise, to augment the heart rate, together with a physiological sensor, to provide more proportional heart rate response during exercise. Programming rate adaptive parameters. The parameters for programming rate responsiveness include lower activity rate, upper activity rate, atrial tracking rate. Many pacers have algorithms that record beat-by-beat heart rates to provide immediate feedback and calculate what the optimal rate-responsive programming should be. Complications of pacemaker implant. Subclavian arterial puncture, pneumothorax, hemothorax, air embolus. Rarely, a lead may be introduced into the left ventricle through a subclavian arterial puncture or through an unrecognized atrial or ventricular septal defect. Cardiac perforation. Infections related to pacemaker implantation, rare, but much troublesome. Venous occlusion, resulting in superior vena cava syndrome or thrombosis of the subclavian vein with ipsilateral arm edema. Mechanical complications. Loose set screw with increased impedance and intermittent or complete failure to capture. Insulation break with oversensing, undersensing, and failure to capture. Lead fractures with increased impedances. Fracture of a retention wire causing cardiac perforation. Twiddler's syndrome occurs in patients who manipulate their pulse generator, causing twisting of the entire pacemaker system. This results in lead dislodgement or fracture. This syndrome may also result from an excessively large pacemaker pocket allowing rotation of the pacemaker. Electromagnetic interference with pacemaker function. Electromagnetic interference, EMI, can originate from a variety of sources that have the potential to adversely affect the pacemaker function. Unipolar pacemakers are usually more susceptible to EMI than bipolar pacemakers because the sensing circuit encompasses a larger area compared to bipolar sensing. Hazards of EMI to the pacemakers. EMI often causes electrical noise that causes the pacemaker to function in a noise reversion mode, switching to an asynchronous pacing mode. After elimination of this interference, pacers generally revert to the previously programmed mode, however, they may revert to a backup pacing mode. Inhibition of pacing output can potentially be life-threatening for patients who are pacemaker dependent. Inappropriate ventricular pacing may occur in patients with DDD pacemakers if the EMI is interpreted as atrial events. Occasionally, EMI causes permanent damage to the pulse generator, especially the complementary metal oxide semiconductors that are part of most modern pacemakers. Cellular telephones may cause intermittent effects like those caused by magnets. Cardiac resynchronization therapy, CRT. Approximately 30% of the patients with chronic heart failure manifest intraventricular conduction disorder, with QRS intervals longer than 130 millisecond. Intraventricular conduction disturbances of the left BBB type result in delay in the activation of the left ventricular free wall, as compared to the septum and the right ventricle, causing intra- and interventricular mechanical dyssynchrony. Ventricular mechanical dyssynchrony is associated with paradoxical septal motion, reduced left ventricular stroke volume, due to shortened diastolic filling time, and prolonged mitral regurgitation. CRT pacing in dilated cardiomyopathy depends on biventricular pacing, which has been shown to coordinate the septal and the free wall contraction. Decrease atrial filling pressures. Decrease mitral regurgitation. Improve diastolic filling. Improve cardiac output. Improve left ventricular ejection fraction. And reduce myocardial oxygen consumption. CRT pacemaker system. In addition to the usual right atrial and right ventricular leads, the biventricular pacing system uses an additional lead to pace the left ventricle, from behind, via the coronary sinus and its tributaries. Mode of pacing in CRT. The objective of CRT is the maintenance of consistent biventricular capture, all OR most of the time, to achieve the required synchronization. Pacing mode is selected as usual based on sinus and AV node functions, presence or absence of chronic AF or paroxysmal SVT, need for rate-responsive pacing, etc. The optimal AV interval is defined as the shortest interval able to produce full ventricular capture by pacing, without fusion with intrinsic QRS, with no impairment of diastolic filling. This can be optimized by Doppler echocardiography to the shortest AV interval that does not truncate the A wave on pulsed Doppler of the mitral inflow. ECG varies in CRT pacing reflecting the balance between left ventricular pacing, right BBB pattern, and right ventricular pacing, left BBB pattern. Position of right ventricular lead in apex or outflow tract. Position of left ventricular pacing lead in posterior or anterior cardiac vein. During biventricular pacing with right ventricular apical lead. Prominent R waves in V1, V2, and AVR, indicating predominant left ventricular pacing. Small Q deep S waves in leads 1 and AVL. QRS axis is usually in the right upper and occasionally in the left upper quadrant. During biventricular pacing with right ventricular outflow tract lead. QRS in V1 may be negative. QRS axis is usually in the right lower quadrant. Negative QRS in V1 with CRT. A negative QRS complex in lead V1 should warrant further evaluation. It may occur in many conditions. Incorrect lead V1 placement. Fusion between left ventricular pacing spikes and native impulses conducted via the right bundle branch. Marked left ventricular pacing latency. Marked left ventricular intramyocardial conduction delay. Loss of left ventricular capture. Left ventricular lead misplacement, middle or anterior cardiac vein. Left ventricular lead dislodgement. Adequate assessment of CRT. Adequate assessment of CRT should include evaluation of right ventricular only and left ventricular only pacing. Fusion is diagnosed if asynchronous pacing or a very short AV delay resulted in the appearance of dominant R in V1. Left ventricular pacing latency or delayed conduction is diagnosed if programming VV pacing with the left ventricle before the right ventricle resulted in the appearance of dominant R in V1. Loss of left ventricular capture is ruled out if left ventricular only pacing resulted in the appearance of dominant R in V1. Otherwise, left ventricular lead misplacement or dislodgement should be sought and corrected. Thank you.